Hello, everyone. Happy New Year. Welcome to another year of Riverside Talk. My name is Denise Mananis. I am the AVP of External Affairs for St. John's Riverside Hospital, and I'd like to welcome you all back. Before we begin, I would very much like to thank our producers and my team that put these programs together for our community. Jason Latour, who is our media production manager, he's our producer. Nancy Anabi is our community liaison, and Candace Cousins-Hopkins, our associate director of external affairs. So before we begin our program, I want to let our audience know that if you do have questions, we welcome them. Just put them in the chat and I will look at them before the end of the program, and then anything that has not been covered, I will ask those questions at the end. And also, I'm so thrilled to be able to welcome today a whole host of new partners in the community that are working with us to make these webinars available to the community. The Ashling Irish Community and Cultural Center, the Department of Veterans Services of the City of Yonkers, Ardsley Parks and Recreation, Ardsley Senior Center, Bronxville Community Center, the City of Yonkers, Community Baptist Church, Hastings Community Center, the Irvington Community Center, Westchester Jewish Community Services, Yonkers Pathways to Success, Yonkers Neighborhood Naturally Occurring Retirement Community, and the Yonkers Public Library. And if there's anyone out in the audience that would like to partner with us, please feel free to send us an email. Those will be posted at the end of the program. And now I'm very thrilled to welcome back a speaker that has been with us before and is our go-to guy for all things pandemic. And so let me start by giving his bio. Dr. Rajendra Rampersaud is currently our Chief of Medicine and Intensive Care here at St. John's. He is triple board certified in critical care medicine, pulmonary disease, and sleep medicine. In addition, Dr. Rampersaud also leads the Sleep Center at St. John's Riverside Hospital. During the height of the COVID-19 surge, Dr. Rampersaud was identified as the pharmaceutical lead for the hospital. He truly is one of our healthcare heroes. His efforts to make advancements since COVID include driving St. John's participation in the Mayo Clinic's largest plasma program, the largest one of its kind in the US. And finally, after attending medical school, Dr. Rampersaud did his residency and fellowship at St. Vincent's Catholic Medical Centers in New York City. And he's just an all-around great guy. And so I want to welcome him to our program again. Hi,
Thank you,
Doctor.
Denise.
You're
That was a
welcome.
very kind introduction. Thank you.
Well, you're very welcome. And it's really true. We do. We love you, and we do think of you as one of our heroes. So let's start. We have a lot of things to cover. Where are we now? There's been a lot of media around RSV, flu, and COVID, and I think it's been very confusing for our community because a lot of the symptoms mimic one another. So can you talk about what they are and how they're different? And are we still in the middle of a surge?
Sure. That's a great question. And I think, even for healthcare practitioners, it tends to be a little confusing because, viral illnesses present in very similar ways. So just to start with a little bit of good news. So the good news is that, most of these infections are on the decline. And when you look at the numbers, it's technology is amazing because there's a lot of data out there and there's a lot of numbers. And you can actually go to the CDC website, you can go to the New York Department of Health, and you can actually see reporting data. So it's actually broken down by days of the week. And so in general, these infections are on the decline. So that's a really good thing. So what I'll do is maybe to make it a little bit easier to follow, I'll start off with each individual one. So for example, flu, one of the things during these infections and pandemics is that it's amazing the ability for us now to have testing at home. And so what happens is when you look at the numbers, there was this sort of concept that the numbers just look really high and really terrible because there's more people testing, which is a true thing, right? Because if you have now, only 1,000 people able to be tested in the healthcare environment, but you have 10,000 able to test in the community, and we know they're positive, the numbers just seem astronomical. So in terms of the flu, we still have a 5% positivity rate in New York itself, but in general, there are pockets around the country where the numbers are high. But when you look at it as a whole United States, the numbers are declining, fortunately. One of the most striking things that we know about the influenza is that there's a 36% decrease in hospital admissions. So that's a really important number for us, and that's across the United States. So obviously there'll be pockets of the country where the influenza cases are a little higher and a little bit lower, but in general, when we start to see that the admissions are going down, we start to have a little bit of relief. And this is a function of, heading into the springtime. It's a function of people who are vaccinated not having severe illness. And, it's funny because maybe about a year or so ago, I was giving a talk in one of the church communities, and she must have been 10 years old. And the question that she asked was, well, when I was a baby, I got some vaccines that would not let me allow to have those diseases. Why do we still get these viruses? Which was a phenomenal question, because the vaccines actually prevent hospitalization, severe illness, and death. And I think that's a really important thing for people to understand, that, they're not meant, unfortunately, by the nature of them, to prevent the patient from actually contracting the disease process.
So that's a very interesting point, because I feel like, to that child's question, we grew up being vaccinated and it prevented getting it. But these shots, like a flu shot, and I guess apparently the COVID shots, don't function the way those vaccines for polio and diphtheria and mumps function. These function in just not allowing people to have severe illness.
Correct.
And death.
That's correct. And hospitalization.
And hospitalization.
Right.
Okay.
So I think maybe we start with influenza. So, influenza is, I'm sure everybody sort of hears information about it. And, one of the amazing things is that, influenza has sort of wiped out significant portions of the planet's population several times in our history. I mean, during the 1913 flu, it's estimated that 30% of the world passed away from this thing. And,
wow.
I mean, it's amazing because they obviously did not have the technology for vaccinations and all the things that we have now. So with the influenza, there's two types, basically. There's A and B. Those are the main subtypes. And the way the vaccine works for the influenza is that it's called an attenuated vaccine, which means that it's a weaker version of a virus. So when people say, well, I got the flu shot and I got the flu, that's actually not possible. And it's very hard to convince people that's not true, because the symptoms you get from the vaccine, basically what it does is it introduces a little piece of material for our bodies to now make antibodies. And so what happens is when your body is doing stuff for you, you will have a little bit of fever, you may have a little bit of discomfort at the site, you may have a little bit of a high heart rate, you may have some body aches and myalgia, but it doesn't mean that you actually have the infection. It means that the machinery and the processes in our bodies are now making antibodies for you. And that's basically how it works. Okay. So the symptoms are very similar. And to get back to your first question, it's hard to sort of tease out, well, do I have COVID? Do I have flu? Do I have RSV? Do I have parainfluenza? Do I have a bacterial infection? So the symptoms are very similar because all of these infections basically come into our upper airway. So a lot of them start off as some runny nose and sniffles and sore throat, and I'm sneezing and I have a headache. So it's really hard to decipher that. And we'll talk a little bit more about that. So with the influenza vaccine, I know a lot of people are sort of hesitant because they think they may catch it. But again, that's not something that's really possible. And one of the things that is really important to understand about influenza is that we look at the rest of the world, and it takes about 6 months to make our flu vaccine on average. And so what has to happen is our scientists and our colleagues who work in virology have to sort of look at what's happening in other parts of the world and say, okay, there's these certain viruses that are out there and we're going to make a vaccine now, but it's almost like having a 6-month lag, because whatever we're producing now is going to cover the vaccines that are in that part of the world. And, we're hoping that most of them will stay the same, but, the viruses can be smarter than we are, a lot smarter. And so their genetics change and they have different things. So I remember during COVID, We had a patient that we were sure had COVID, and this was a time where testing took a while. It turned out that that patient actually had the 2009 H1N1 swine flu.
My goodness.
So, right. So these things are out there, they just don't go away. But, they may be harbored. They may be, in a sort of like a hibernation phase. So, there's basically a lot of different variants of it. And the ones we deal with are influenza A and influenza B. So we're sort of lucky because when you get a flu vaccine, it's actually called a quadrivalent vaccine, meaning that it actually covers 4 flu types. And so the predominant flu, for this past year has been influenza A, type A, and there's multiple types. So for example, this year we were specifically, for the scientific people out there, we were dealing with the H3N2. And it's always amazing to me how our scientist colleagues can figure this out, right? How they give it letters and numbers and know that it's particular things. Now, unfortunately, in the community, and especially in smaller communities, we don't actually have the sort of apparatus to say, okay, Mr. N, you actually had this strain of influenza. And in the grand scheme of things, it may not make a huge difference which strain it is, but when they follow these things, this is how other countries know, well, you had this, we're going to get this. So that H3N2 type A influenza was about 79% of all the flu infections we've been seeing. And then so there was basically 2, you get 4 for the price of 1. So it's a quadrivalent vaccine. So it covered the 2 type A's and the 2 type B's. Now, the great thing is that unfortunately, we don't know how effective the vaccine was until the following year after they collect all the data. But just to give you a little bit of perspective, so in 2014, 2015, the influenza vaccine was probably one of the least effective. It was only about 19 to 20% effective. And sometimes I hesitate to tell those numbers because it just sounds really bad, right? But if you imagine that we have, 350 million people in this country, and whatever percentage are going to get vaccinated, including our babies, if we now prevent death, illness, hospitalization, even on 20% of those people, that's actually a big number. In 2011, the number was about 60%. We're sort of getting about 43% across the board.
So the numbers are better, but
right.
you do have an occasional fluke.
Right. And and that's the thing, because I think as now science is advancing and they have different technologies now to look at vaccinations and to make vaccines, they are getting more efficient. But the problem is that we have about a 6-month lag. Okay. So in order for us now to make the vaccine, we have to make it geared to what other countries have been experiencing.
All right. So you said before that the flu numbers are going down also.
Yes.
All right.
So influenza is definitely going down. There's a 36% decrease in the general hospital admissions from these conditions. And like I said, influenza is something that COVID sort of overshadowed. But every year there's around the world, there's probably about 500,000 people that die of influenza.
So it's something the numbers to be taken seriously every
absolutely
year.
Yeah.
Okay.
Yeah.
So then let's go back and talk about COVID and about all the strains, because that's what gets a lot of media. And
right.
And we know that both the flu and COVID present very similarly.
Right.
So what are the new strains? Are there more coming? What's the story now? Because a lot of people think it's no big deal. Now it's a cold. Is that real?
So, the one good thing, and this is a function of virology, is that once the viruses now start to mutate and the vaccination rates go up, hopefully, people who have innate infection now develop antibodies. There's a concept that the vaccines cause new strains. That's not true. So actually, when you vaccinate a population, it actually decreases the genetic strains because there's less infections now happening. So with the COVID, which, sometimes I look back and it's hard to imagine those were the days we were, in the trenches of this, right? Especially here at St. John's, right? Where we were, our general population in the hospital was up over 300% capacity, and our ICU was up 400% capacity. I mean, those numbers are astronomical,
I remember.
And so looking at it as a big picture, there's been almost, 680 million COVID infections around the world. I mean, isn't that number is absolutely astounding to me. You know, it's almost 700 million people. Now remember, this is cohorted, collected data of places that have the capacity to report. So if you have other parts of the world where, you know, people are overcrowded and there's very poor healthcare access and there's no testing, and, you know, these unfortunate individuals may not have had any access while they were infected. So you can imagine that number is really, really much higher. And, you know, so Johns Hopkins University, they actually have like a world meter. So if you go to their website, you can actually see a running tally of a lot of this data. So if you imagine, they estimate that that number may be lowered by 30–40%. So it's over 1 billion people who have had this infection. That is an astronomical number. Unfortunately, there's been, you know, many deaths. So, you know, almost 7 million deaths from this. And in the US, unfortunately, we were the country that had the most infections and the most deaths. So we were actually the country by far, even though our, you know, geographic size is not as big as China or India. And again, this is reporting, right? So maybe it's underreported. People weren't, you know,
elsewhere,
putting
right.
right. So, but just in terms of the sheer numbers of what we have survived, what we have pulled through, what we have moved forward from, it's a staggering number. And I always like to tell people the numbers because sometimes it gives us a perspective that we went through something real bad and now we're like in a better place for it, right? So there's a lot of variants, and the variants are based on Greek letters, basically. So it sort of depends on where things show up. So for example, you know, there was the alpha, and then along came beta, and everybody heard about the delta, and then, you know, and the Omicron. So right now we have a whole bunch of them, and, you know, the letter that they start with is the letter B as in boy. So there's the BA4, there's the BA5, the BQ1, the BQ11, there's the XBB 1.5, which right now is the predominant sort of viral strain. The great thing is that the virulence is less. So we definitely know that if somebody was unfortunate to contract COVID in that first 2019-2020 pandemic, that virus was much more virulent. The chance of that virus making you ill, sending you to the hospital, and causing death was actually very high. As the virus has changed genetically and we have different strains, in theory, the viruses become less virulent, but now they become more infectious. So it's easier for somebody to catch the infection. It's a little bit easier for these viruses to be transmissible, but, you know, they have much more less chance of sending you to the hospital and dying. One of the things that's been very unique about, you know, these viruses is that spike protein. So that's why it got the name the coronavirus, right? Because it looks like a little crown. And that's what actually attaches to the receptors in our airway. With the most recent genetic strains, there's more than 30 mutations on that little spike protein. So that's why it's more infectious. That's why it's more easily transmissible, because now with all these, you know, genetic strains, it has multiple ways now of attaching into our respiratory tract.
Okay, so let me just clarify this. So it's more infectious. There are more strains. It is still here. It's going to be here, I imagine. But can people? I think there's a lot of conflicting media. There's certainly things that are political in the way things are reported, and I think we can acknowledge whatever side you're on, you know, one thing or another. But most people are tired of masking, and they're suspect of the vaccines, and there's a lot of concern around all of the, you know, way we've had to adjust our lives. Can you talk a little bit about where how we should proceed?
Sure, and that's a great question, and, you know, and I don't know if there is a right answer right now, but we can definitely make you know, some headway with that. So in terms of the infections itself, you know, it is a good sign that there's less hospitalization. So again, a little bit of good news. So in the last week in Westchester County and in Yonkers, there's this is several weeks, probably a few months, there's been no deaths from the coronavirus directly. When you look at cases over the past week in New York, there's been about 110, but, you know, we were at a phase, you know, back when this XBB 1.5 came out. There was, you know, in December of 2021, there was 1 million new cases of Omicron every day. 1 million new cases every day that was reported. So in terms of the numbers, it's a significant reduction in the numbers, and the deaths from directly from coronavirus is significantly reduced. So those are all really good things. And again, it's a function of vaccination, partially innate infection, partially people still doing hand hygiene and all these things. But the vaccines have a really important part of that. And there's a lot of debate with vaccines. And, so just for me, for example, so I've gotten 5. So I've had 4.
Me too.
Yeah. So and somehow, which nobody believes, is I don't think I ever had the infection. Wow. Yeah, and it's so the thing is, then there's a lot of research going on. Is it blood type? Is it genetics? Is it something?
For our listeners, for our audience, I do want to just say that is a remarkable statement to make, given that you were sort of sequestered in our ICU at the height through the entire surge in 2020. For those 10 weeks, where our lives were so altered in the hospital. I know you were with all those poor souls who were sick and dying, and for you to say that you didn't get it is really remarkable.
Yeah. And, and again, it's sort of like it teaches you that simple things work, so I was a fanatic about goggles, face masking. I would actually double mask, with the N95 and a surgical mask. And so those things, even though they're very simple and they, for lack of a better way to put it, they can be annoying because, now I have some nasal stuff and people are like, I have a little line on my nose, and and I'm an old guy and I was getting acne on my face, and my son was making fun of me. I was using his acne medication, so it did change a lot of things for us. It may not have been the end of the world, but there were things.
Do you think that we should still be masking?
Personally, I still do. So if I'm out in public and I try to go to places that are common to me and that I know have good cleaning processes and things like that. But if I go to a larger venue, I still will wear a simple surgical mask. When I'm in the office, I wear an N95 mask. So there's a lot of guidance now that says that we really don't have to do it. And I think it's an individual thing and it's your risk, right? So if you have diabetes and you have kidney disease and you have heart disease and you've had a stroke and you have asthma and you have COPD and your sort of baseline medical health is not the best. If you have cancer, if you're immune compromised, it's not the worst thing to happen. And I get it, we all want to move forward and feel like there's some normalcy happening back in our life. But like I said, the numbers are tremendously better, but they're not zero. And, to be honest, we're never going to get to zero. But it's something that I think in very simple ways, we can incorporate back into our lives. We don't have to be as fearful as we was in the beginning when we had no idea how this was transmitted, what the safe distance was, that, hand hygiene really is a huge, important step in avoiding illness, So I think that we will get back to some quote unquote normalcy, but it won't be the way it was in early 2019. I think things have definitely changed since then.
Okay, so let me ask you this then. There's been also a lot of press regarding the vaccines and their safety and now when prior to COVID, when people got the flu vaccines, that was recommended for, as you say, the immunocompromised, senior citizens, little children, babies who don't have a developed immune system. So this is two-parter. So one is that the way that people should go forward with flu vaccines every year, flu shots? And is that what is recommended now going forward for COVID vaccines? Because there's so much pushback of, I don't know, it hasn't been around long enough. Right. What has it done to me? So what's the advice on that
Sure.
score?
And again, that's a great question. And I think, there's several parts to the answers and some of it is unknown. And I think that, for all of us being a human being, the unknown is really the scary part of all this. And again, people have to individually look at their risk benefit of getting something. So, especially now that the viruses are much weaker, people are like, well, I'll take my chances and I'll have a mild illness. The problem becomes is the long COVID symptoms, which we can touch upon if anybody's interested. But the first thing I'd like to talk about is the effectiveness of the vaccine. So if, the latest sort of data from this, and this is independently sort of dependent on the company and also independently reviewed by major institutions. So the bivalent vaccine has been about 59% effective against hospitalization, which is a huge number. So when you think about more than half of the patients who have received and again, the flu vaccine is quadrivalent, meaning there's 4. The bivalent means that there's 2. So basically what happens is that it tremendously reduced the admissions to the hospital to decrease the burden that it's been creating on healthcare. The monovalent, which was the single shots that we got in the initial series, because I've met a lot of patients who've only had the initial series. And then they either had COVID once or twice, maybe 3 times, and they're like, well, I don't really think I need it. So with the monovalent vaccines, the effectiveness was about 25%, which sounds like a really low number. But again, when you're thinking about the population and then preventing getting you into the hospital, again, it's good. In terms of the effectiveness against getting the infection, because in the course of the past 3 years, I've had direct exposures from my family or colleagues that it's like, oh, by the way, I have COVID now, and we were having dinner the other day. So it's about 62%, a little under for effective against infection, and with the monovalent, it was about 25 again. So those are actually very good numbers when considering how widespread this is. Again, the vaccines could be given for 6 months and older, so pretty much anybody can take it. And again, pregnant women and children and the elderly are the ones that have more of an issue of getting it. Whenever there is an issue with a vaccine, there is a reporting system. Now, the reporting system is an open system where, say I received the vaccination and I felt that I got like a runny nose from it, even though at the same time I was exposed to influenza. I could actually go through that reporting system and report back to these sort of people who collect the data that I felt that I got something from the vaccine. Obviously, we do know that COVID itself causes lots of different injuries in different organs. So one of the amazing things is that if you really are a science buff and you want to learn about the viruses, you look at science journals. So of course I'm like, trying to get my hands on everything I can read. So Science is a good journal. It may scare you a little bit, but they've actually found the coronavirus in about 81 different body tissues in our body. And they actually found the coronavirus in our brain, which means it can cross the blood-brain barrier, which a lot of things can't do by grand design. So this is the mechanism of how people are getting a lot of long COVID, because the viruses particles, they're not alive, they're not causing a tremendous amount of infection.
But there's residue.
Right, and the residue can last for 6 to 7 months. So this is a mechanism of the long COVID symptoms, because it's basically irritation, inflammation in different body structures, And again, the more we learn and the more we learn how to deal with these things, eventually it'll become better for people. Unfortunately, there has to have somebody who got the infection or had something negative for us to explore it.
So if anyone in our audience is experiencing long COVID, at the end of our webinar, we post our info@riversidehealth.org email, but they can certainly send us an email and we can pass that information on to you. And you said earlier that you would be happy to talk to some folks about long COVID and long COVID symptoms. And so, but you said 6 months, but there are people who are experiencing long COVID for longer than that.
Sure, and the reason why is because of these inflammatory changes and whatever else the particles are doing, it's leaving sustained organ injury. And so
go ahead.
Yep, sorry, go ahead.
So if there's sustained organ injury, is there remedies for these?
There are, we're still learning, because again, we can't quote unquote cure the common cold, right? And so these type of viruses, for example, a lot of people when you look at antibiotics, so people who, have dealt with me on a clinical level, they know I'm very stingy with antibiotics because 80 to 90% of antibiotics prescribed in the community is not needed, actually. And a lot of them are due to viral infections. And even if the patient had a COVID infection or influenza or even RSV, they're like, take a Z-Pack and it'll all be okay. The reason why you feel better after the Z-Pack is because of timing, right? So you've given yourself another, 5 to 7 days, and that's the natural history of a lot of these virus infections. And you're gonna be like, wow, that Z-Pack was amazing. So every time now I get a runny nose, I want a Z-Pack, so that's actually not a very good thing in general. Now, in terms of, one of the things that's really dramatic is what happened before the vaccines were here. And so a lot of the effects and a lot of the things that the vaccines have sort of been questioned to complicate were there before. So for example, one of the big things, and it's one of the things that I'm very interested in because we saw a lot of it, is thrombosis. So meaning clots. So prior to the vaccinations, when the patients were coming in purely with, COVID infection, and we thought that, Plaquenil was life-saving, and we thought this was life-saving, and all the things that we were doing in the initial phases of how we knew how to manage COVID, we were seeing all these conditions prior to that. With the vaccines, there is a slight increase, and I hesitate to say slight, I hesitate to say numbers, because, if the person who had that effect was me or you or your husband or your child or my child, it wouldn't feel good. But they've probably given 10 billion, maybe more doses of the vaccine around the world. And if you can imagine that number again, it's an astronomical number. So when you look at the actual percentages of reported and confirmed side effect of these vaccines, it's basically nominal. But again, if it affects you or me or our loved one or our friend or somebody in the community, it just seems like, wow, that was a terrible thing that we took the vaccine, and maybe we should not have done it. It has saved countless lives. There's no question about that. We actually know that if you are vaccinated and you have COVID infection, it reduces your incidence of long COVID symptoms. It reduces your incidence of, lengthiness of the infection itself and symptoms. So again, these are all positive things, but yes, okay, there are, and the ones that have gotten the most sort of press and the, sort of the limelight are cardiac things. So it can cause something called myocarditis, which is inflammation of the muscle. There are cases of pericarditis, which is the sac around the heart. These are generally things that are treatable. And, and again, the more we encounter, the more we learn how to look for them. Because if this was, March of 2020, and at that time, none of us were really looking for pericarditis because it was like, well, this is a respiratory virus, right? It's affecting our respiratory system. But, again, as we learn more and our science colleagues and all the other people around the world trying to figure this out, give us information, we have a much better heads up now that when somebody comes in, we have various testing and sort of assays and physical exam findings that we look for to say, okay, we're going to look for these things because we know they can happen to our patients now. So, I honestly feel that we're very much ahead of, where we were, before. In terms of risk. Yep.
Yeah, so I just wanted to ask you, based on some of what you started with today, one of the questions that we get is, are we expecting another surge? Can we predict that surge? And it's like predicting the flu. I know that nothing is an exact science here, but are we tracking data for COVID? But I do want to also ask about RSV, because that showed up this year.
Yeah.
And who's heard of RSV and why did it come this year? So I do want to work that little question in.
So, in terms of prediction, again, we sort of look at what's happening over in Asia and Europe, and there are little pockets, but the good news is there aren't large pandemic type of things. So basically these viruses now become endemic. So they're around, they're here. We know how to monitor them. We know how to test for them. In terms of the risk, so for those who are listening, they said, well, am I at risk? So again, people who are immune compromised, if you've ever gotten any type of transplant, if you've had a history of tuberculosis, which is not that uncommon, weight is a big one. Physical inactivity is listed as a, high risk. People don't think about that, but we see it all the time because unfortunately people were landlocked in their houses. And just a quick little thing, I always like to tell the patients in the community, it is safe to come back and get your checkups and your screenings. And so in the first 7 months of the first pandemic in 2020, they estimate that about 7 to 10 million people did not have their cancer screenings that they should have. And it's unfortunate because every once in a while I have a patient in the ICU. We have a patient, recently who hadn't left her home in 2 years because she was so afraid of coming out of her home. And what we're seeing now is a lot of patients coming in with a lot of other medical illnesses that are not caused by COVID, but are caused by, I had this issue before and now I just didn't get it taken care of. Right. People who have sickle cell are high risk, people who smoke are high risk, asthmatics. Even though this is a sort of a number, I don't know if it's good or bad. It's not meant to be demeaning, but if you're 65 and over, you're considered high risk. So I have patients who are in their 90s who, are in great shape. So, but, just by the numbers, because the population 65 and over, that comprised about 80% of the deaths from COVID. So, by the numbers, people who have substance abuse disorder, and unfortunately, that's a big thing that we're seeing now because of a lot of different reasons. So in terms of just a quick thing about the treatment for the COVID now, earlier on, like you mentioned, the plasma, and the plasma data has actually sort of flourished to be just has to be high concentration plasma, meaning that when we were giving it before, it would be harvested from somebody who had COVID. We would take their antibodies. We were not able to check if it was a high level of antibody. And we suspect that's why it wasn't working as well, because we were just giving it. The other thing too is we were giving it to patients who were very, very end stage, because we just didn't have anything else. And so that skewed the data. The Paxlovid is the oral medication now that they use for it. And it's actually very, very, very good against the COVID for hospitalization and death. So it actually reduces your chance of hospitalization and death by almost 90%, 89%. So if you were in that list of high-risk patients, and you take Paxlovid, now the timing is important. So it should be ideally the sooner the better, but if you're within 5 days, it still has some effectiveness. If it's beyond 5 days and you take it, it won't be as effective, So this can be given to anybody above the age of 12.
So then that's the treatment that you want for COVID, and people should be aware of that timing. Yes. And when to come to the emergency room. Exactly. But or your what doctor. About the flu? Because are there similar types of treatment for the flu?
Sure. So, with the flu, it's the Tamiflu. And so the Tamiflu, now, when the Tamiflu was produced, it was really produced because people wanted to reduce symptoms. So the Tamiflu, we know, reduces symptoms, but that is most effective within 48 hours of your symptoms. So say your symptoms are 3 days later, again, the sooner the better. So if you test positive and you are on this high risk list, the Tamiflu will reduce, but it really hasn't been shown to reduce death and hospitalizations because it really wasn't looked at. Because people kind of felt, well, I have influenza, I'm just going to ride the symptoms out. I just want to make the symptoms shorter, so the Tamiflu will reduce the illness by about a day or so. RSV. So I know RSV has been a hot topic. And, one of the things is, again, life is a lot about perception, right? So RSV has always been there. So prior to these past couple of years, RSV was the highest leading cause of hospitalization in our babies. So if you were less than 1 year old, the chance of you ending up in a hospital is from an RSV infection. And, recently, we've sort of been seeing it, right? Everybody's afraid of this like triple-demic that they've been calling it. And we actually have patients, and, it's ironic because I remember maybe about a year ago, there was all these reports all over the world of a co-infection with flu and corona, right? The florona. We actually had a case in 2020. And I was like, we should have written that up. Yonkers would have been on the map, right? Like we had a florona infection. So these things are all over the place. And I mean people all the time who are like, I had
So that
flu, I
was
had
two,
this.
or was that all three?
Well, I haven't seen, and I don't think any of us have seen anybody that had all three. I mean, you have to be pretty unlucky if you're gonna get all three. It is theoretically possible, absolutely, to get it, but there hasn't been many case reports of those unlucky folks, but it can happen. And one of the things, again, in terms of, well, why did it seem so prevalent? So RSV is basically the respiratory syncytial virus, and it's been around forever. And again, the rate of the RSV, the positivity rate is very low right now. So the positivity rate is about 1%, which is very low. More good news, we are coming out of the RSV infection time, and those numbers are significantly getting lower. So one of the things I think, because of the nature of the viruses and the weather and other factors, is that we had an early influenza and RSV season. So there was just more time to sort of have the infection running rampant that people can get it. Prior to COVID, there would be at least 2 million outpatient visits of children under the age of 5 from RSV.
Wow.
Prior to COVID, there was at least 80,000 children hospitalized from RSV. Prior to COVID, about 160,000 adults greater than the age of 65, 100 to about 140, maybe 160 in a really bad year from RSV. So it's always been there. It's just that, people were like, well, I had RSV, I had influenza, now Corona came along, it took the spotlight, and people are like, oh my God, like this is the worst thing. And now the flu is trying to kill us. Now RSV is trying to kill us. It's like a complete onslaught, right? Like nothing's giving us a break. So the RSV has been there. One of the things that's really amazing, and people look at this and they say, well, why was it so terrible? Like, why was it that we just had patients now in the hospital that we felt we just never saw before, even though we had been? And it's a couple of things. So one of the things is that the routine of protecting ourselves from COVID, the masking, the hand hygiene, the social distancing, people staying in their homes, sort of drove those numbers down in 2020 and 2021. So those years, it sort of fell off the scale. And people were like, all right, RSV no longer exists, even though it does. And the numbers just seem so much worse. The other thing that happens, which is, an amazing concept to me, is exposure. So, they have those parents that, they're constantly on their kids and they're washing their hands, and not that that's a bad thing, but in order for us to build immunity, there has to be very small amounts of us getting something exposed to us. And because of the isolation and all these other things, there was very little exposure during those years. And so now when people actually get, and that's the whole concept behind vaccination, right? So I'm going to give you something that's going to create some antibodies. It's going to be a weakened virus. It's going to do something in your system to give you a little bit of memory that if something actually infects you, that you can actually fight it much more effectively. When people don't get exposed to things, they don't build that immunity. And that's basically what we call an immunity gap. So for this amount of time, because people were having very low levels of exposure, they weren't getting these antibodies built. They weren't getting immune system, tolerance in order to now fight something when they actually had an infection. So by far, that was probably the biggest reason, why we saw a lowering in the numbers during those couple of years. Now we're seeing an uptick in the numbers.
Right.
In terms of treatment, there's no specific treatment, although there are some monoclonals, but for RSV, the monoclonals are actually reserved for preemies.
Those are antibodies, right?
Right. So they're antibodies. So basically, what these are is they're scientifically engineered antibodies directed against the viruses. And so early in the COVID course, we had monoclonal antibodies, which we provided here at St. John's to a very high degree, and they were a home run. And then what happened is the viruses got really smart, and then they changed genetically, and then they were no longer effective. The monoclonals weren't effective against those viruses. So several months ago, the CDC and the FDA said the activity is so low, we're just not going to dispense them. But if you're a preemie and you have cardiac or pulmonary problems and you're a small baby, there is some monoclonals that can be used. And then the other thing that's really good news, but again, it's a vaccine, is that they are going to put out a vaccine for pregnant women for RSV. And the reason why it's for pregnant women is because if you look at the demographics of the patients who get infected, are those little ones less than 12. So by giving it to the mom now builds
antibodies
and passes it to the baby.
Right.
So for the first 6 months of your life, at least, you will be protected. And that's the population that has the most morbidity and mortality from the RSV. Now, once that sort of, I guess, becomes more mainstream and, more utilized, they will sort of hopefully extend that to other people who are considered high risk, but that's on the horizon. So that's something that is going to hopefully be FDA approved pretty soon.
Okay, so I have some questions, some from the audience, and but I just want to kind of recap. So, and one of these is partly from a question. The time to act when you have symptoms. So going to the ED or going to your doctor and starting Paxlovid is within 5 days of the onset of symptoms?
Correct. So ideally it's within 5 days. Right. Now the thing is that just say you're at day 6 and you have a kidney transplant and you're a diabetic, so
still go.
Yes, because there is still some activity,
All right.
And again, it's sort of like they're actually doing clinical trials now. And I also sort of hesitate about clinical trials because everybody's like, well, I don't want to be a test animal, But unfortunately, sometimes we need a little bit of experience to make good decisions in the future. So they're actually doing some clinical trials now, looking at longer courses of the Paxlovid to actually decrease long COVID symptoms. Because if the concept is that the virus, so the way the Paxlovid basically works is there's 2 medications in it. So one isn't their antiviral medication, meaning that they tell the virus you have to stop replicating. So if you stop the virus from replicating, the symptoms start to abate and you get better sooner. The other medication in it utilizes our body's ability to decrease the clearance of the drug. So the drug now gets a little bit of a higher state. So what they're looking at is to say, well, if it did such a good job and the reduction of risk of hospitalization and death was so good, all of these folks who have these long COVID symptoms, maybe we give it a little bit longer in different doses and smaller doses. Maybe it'll, because people always ask, well, how long am I infectious for? So I don't know if you remember, but, early on, people got 2 weeks off from work, right?
Yep.
It was like vacation time. And I always complain to my colleagues, I'm like, I never got COVID vacation time, right? Because I didn't get it.
Me neither.
So, yeah. So,
all right. So that's COVID. So
right.
The flu, the Tamiflu is 48 hours.
Correct. So the Tamiflu will reduce the symptoms. And in general, if you look at the data, it tells you it's about less than 1 day. But, 1 day earlier feeling better is probably pretty good for most people.
But here's the interesting thing. I mean, I'm on the a little bit older end, and I grew up. You didn't give in to your symptoms, right? You didn't acknowledge them per se. You sort of still kind of toughed it out, went to work, went to school, did what you had to do. You're not really recommending that we do that. You're recommending that we take our symptoms seriously and self-isolate.
Right. Yeah, and again, the basics, self-isolation, especially if you live with somebody who has, a high risk or young on the younger side. And testing is very easy now to get, or urgent cares, or you come through us, through our urgent care and our fast track areas. Right. It's a very rapid test that they can perform on you. And whenever the patients come in, we have a triple assay. So we're going to check to see if you have the SARS virus, which is COVID. We're going to check if you have influenza A or B, and then we can also check if you have RSV. Okay. So it's a pretty simple assay, and they are quite effective at making the diagnosis. So even if to tell you, look, you have influenza A, and it's been 48 hours, so just go home and isolate for a couple of days and hydrate yourself. So I think that again, if you have any type of high risk or you're younger or older, it's good to know what you have, because I think, again, it's the unknown, right? Like, is this the virus now that's going to start to progress and make my symptoms worse?
So we're going back to please don't wait for medical care. If you have symptoms, you should be calling your doctor, coming into our urgent care, or our fast track service or urgent care
Or
close
our
to your
virtual,
home,
our virtual visit. So we
or
have
virtual
right.
visit, which we also post that number. I have another question for you. You had earlier, this is from someone in our audience, talked about the heart effects, the pericarditis. You can say it, I can't say it. The swelling around the heart muscle.
Right.
Is that damage correctable? Is it treatable? Is it, do you fully recover from it?
Right. So that's another really good question. So there's a lot of different things. So COVID has been linked to swelling around the heart, which is the pericarditis, the muscle, which is the myocarditis. It's been linked to heart arrhythmia. So atrial fibrillation, flutter, all kinds of different things. And again, I think that if you have symptoms, the earlier you get them treated and the earlier you get them addressed. And again, what we were talking about before, that the Paxlovid may be something that may prevent long COVID symptoms. Okay. We have patients mostly from the first wave who were completely healthy younger people who, for whatever reason, they still have persistent symptoms now. And we don't know why that is, because they were otherwise healthy, non-diabetic, in good shape. So the symptoms can be persistent. One of my cousins, her husband is a cardiologist, and he actually he has some funding from the NIH to do research on these things. And so, when we're sitting around the family table and we're chatting and stuff, they don't know why, but they think there is a genetic component. Maybe it's the patient's blood type. Maybe the patient had something underlining that was there. And I think more and more when you talk to different people, especially specialists who focus on different organ systems, if there was something in your body or your genetics or in your medical palette that was about to present itself at some point in your life, COVID brought these out a lot sooner. Right. So it took these things and it sort of decompensated them. So we have seen a tremendous amount of people recover. So the numbers that are still unclear, remember, there's been a little under 7 million deaths. But when you have almost 700 million cases, that means that over 600 and something million have recuperated. So now the next phase for all of these folks is for us to look and see, well, what are the symptoms that you have? What's the commonality with them? What's the common thing about you? Right? So at some point, right now they're doing studies on couples. So they're looking at, well, maybe one half of the couple, had COVID and the other half didn't, even though you sleep in the same bed. Like, why is that? Right. So there's still a lot of unanswered questions. So the easy answer is that unfortunately some of these things can be persistent symptoms, but they can be managed. And so the important thing is to come back to healthcare, to come in for an evaluation, see your primary care doctors, look at these different organ systems that we know can affect COVID, and then eventually end up, if needed, to see a specialist to manage them. Because people will get pericarditis and myocarditis from a lot of other reasons, and we manage them similar.
And they do recover from that?
Yes.
Okay.
Yes.
All right. So another question, and this is a very, I think, very typical question because I've gotten it from my mom, very similar to this one. Our audience member says, prior to COVID, I was ballroom dancing, but I'm leery now. Dancing is somewhat exerting and everyone will be breathing harder, but it's difficult to dance with a mask on. So what's the advice? Avoidance, wear the mask. What do you think? And this person, it gives the age and it's 72.
Yeah, that's another good question. So I think that one of the really important things is to get back to life, right? I think that, if you think about being inactive makes you high risk for getting COVID, that we don't want people locked in their homes. It's also not good for up here. Like a lot of us now, it's there's a lot of mood disorders, it's a lot of sleep disorders. A lot of people who had baseline, mental health issues have worsening of these mental health issues. So I encourage people to go out and do the things that they enjoy. Again, it's sort of knowing the environment. So if you're with a small crowd, and the person that you're ballroom dancing with, that person and they're vaccinated and they wash their hands, and don't be afraid to tell somebody, just say you show up and it's like, okay, here's, Mr. M and this is Miss S, say, hey, Mr. M, can you, wash your hands, or Purell or whatever it is. And again, the masking is something that is, always a good idea. It's also being personally responsible. And this is the thing that, like you said earlier on, I remember when I was little, I never missed a day of school. I mean, I hate to admit this because it sounds like nerdy, but I never
No,
missed a day of school until I
never.
graduated high school, right? Because whether I was like, in my deathbed or coughing up blood, like you better get up and go to school because you have to learn, right? So I think it's sort of a culture thing for me to say, listen, I have a headache, I have a runny nose, I have a low-grade fever, I'm having symptoms. Maybe I have something going on, but I'm going to go to the ballroom class and dance with that other person. So it also has to do with social responsibility and people sort of watching out for each other, right? Like making sure that all of our folks around us are also stable. I personally, I actually went to a concert 2 weekends ago. I mean, there was 15,000 people there. I mean, when I went in, I sort of had my mask on. A lot of people didn't. We got to our seats. I always pick like a little aisle seat so there's nobody actually next to me, and sort of judged it by that. So I think knowing what we know about transmissibility, 6 feet apart, those things really work. We know that they work. So if you're going to be in an environment where there's 20 people and you're only going to come into contact with maybe one, to be like, hey, I'm going to be a good citizen for you and you have to be a good citizen for me. So I think it's really important for people to get back out there. And don't be afraid because,
You know what, I want to just make a note of that, because we are hearing there's so much depression and anxiety and concern. We have another physician who just, and it will be live probably next Monday or Tuesday, a podcast that was just done with our chief of psychiatry, Dr. Shapuru, who's talking exactly about that. And he talks about the isolation and why people are so afraid. But I think that you're giving everyone here very practical advice about their mental health, aside from the physical aspects here of not being isolated, of going back out there, but being smart about it. So that actually brings me to the last question from the audience, which is, and I will say people are very creative. What masks do you recommend? Because I've seen some beautiful pieces of art, but I don't know that they actually work. So,
yeah.
What do you think is a good thing for people to be wearing?
So, simple surgical mask is more than fine. And I think, maintaining hand hygiene and, some separation. And it's about knowing the environment, so if you're going to go someplace where you're at a concert and there's hundreds of people standing around you, that's a little harder to navigate. So, when we went to the concert, we went to see Mark Anthony, who's phenomenal, by the way. I had my simple surgical, but then I also had a little N95 in my pocket, just in case, right? That, there was like a lot of people around. And these things are going to happen, I mean, and again, they happened before COVID with influenza and RSV and all the other things. People are forgetting about the bacterial infections. So if there was somebody standing close to me that had, bacterial pneumonia and was coughing up a storm, I could catch a bacterial infection. So I think, moving forward, it has to be built into the culture of what we do, unfortunately, right? I mean, it's sometimes I think, and I'm, during COVID, sometimes I feel sad for myself to say, why is my life like this? But it happens to a lot of us, right? And, we have to be creative and pull it out. The beautiful, and we go down to, because, people were creative. They had all these different masks and, like those who like, sort of, the brand name, you'd have like an LV or Gucci or something, cloth wise, those are not very good to protect you. So, if you want to be protected, a simple surgical is fine. People ask if I fly in a plane, what should I do? If I go, I wear an N95, because what happens is the air is recycled. They're supposed to have filters that filter out the micron size, but just say now there's an XBB2, right? And the micron size is smaller. So, I have patients that come back after they've taken trips, especially across the country or overseas, where they're on the plane for 6 to 8 hours, and they're like, I caught something on the plane, So it's basically, picking the environment. And the other thing too that I think people sometimes don't do is that when you go to your doctor, even though they may not want to answer it, is ask them, hey, I'm taking a trip next month. What do you think I should do, right? So they would have much more information because they have your list of medical illnesses. They have a list of your medications. You know, sometimes for me, I like to give my patients an action plan because they're like, look, I'm going here, like, you know, to the Caribbean. What should I do? Well, find out if they have, you know, a physician there. Find out if the, you know, Paxlovid is available there. You know, find out if they have these different things, or, people who want to be really proactive. You can see, hey, you know, there's an outbreak of influenza on this little island. Maybe don't go to that island during the outbreak.
So you're saying that in general, the surgical mask for sort of casual, whatever, and then for very crowded venues, perhaps maybe the N95s or the K95s, whatever people can get, are better than the cloth, or better than the velvet and the rhinestones, and
so those
all
are
of
definitely
those
better.
things.
We know that, and you could actually go. So, you know, again, they've done incredible data, and again, this is not 100%, but in theory, if two people have a surgical mask on, the amount of time that you need to be exposed, it's probably about 15 to 30 minutes to pick up an infection. If two people have an N95 mask on, it's several hours of exposure time. Okay. So that's why when I'm in the office, you know, I wear the N95 because sometimes the patient's with me for 30 minutes or so. Right. So, but the N95, in theory, if it's fitting well and not like, you know, under your nose and like this is riding up, but covering your nose and covering your mouth with a nice decent seal, in theory, it should be several hours at least of protection from you, even if the other person has the viral infection. Okay, so we have time for one more question, which someone just wrote in, and you had talked about the long COVID symptoms from the heart, but there are other long COVID symptoms. Someone is here is referencing the loss of taste. Sure. But we have to keep the answer a little bit short so that we can close the meeting up shortly. Yes. So what other long COVID symptoms? Right. So the loss of taste is, again, it's because the mechanism of it coming into our upper airway and it attaching to what's called an ACE2 receptor. And so basically those things are in our respiratory tract and they're along our taste buds, and that's why those got affected. Long COVID, like I said, they found it in about 80 different organ systems: brain, skin, eyes, liver, kidneys, lungs, right? So patients can technically have symptoms in any of those organ systems. Now, the good thing is a lot of them tend to resolve, but we are seeing people who have persistent symptoms, even from the quote unquote weaker viruses. And again, that's something yet to be seen of why individually. There's certainly a genetic component of these things. There's something in somebody's gene makeup of why they actually got that critically ill, or you got exposed and you never had the infection. But the symptoms can be very various from mental health to real organ illnesses. Issues. Yeah. All right. So that's kind of a long COVID maybe is another topic that we want to do a webinar on, and I'd be happy to hear from the audience and from our partners. But I do want to tell the audience that this program, for anyone who has missed it, and for your friends and for your neighbors who are interested, it will be on all of our social media platforms, if not tonight, but then by tomorrow morning, it will be on all of the social media sites for St. John's. We do, and Dr. Rampersaud, thank you so much. You are just an amazing, I can't believe the amount of information you hold in your head, but you also lived it, and we really appreciate you sharing your time and your brilliance with us. So thank you. My pleasure. All right, so we just want to give our audience a little bit of closing here. So again, for virtual urgent care, if you think you have symptoms but you don't really want to go to the doctor, or you feel funny about it, please call this number 914-207-0006. They will register you for a virtual urgent care meeting with a physician, and ask for that when you call. If you have information that you would like to share with us, if you have questions, if you want to suggest topics, please call, or rather email us at info@riversidehealth.org. You can also call our physician referral number, which is 914-964-4DOC. That's 4362. Or find a doc at riversidehealth.org. Both those emails, by the way, come to me, and then I disseminate them out to whoever they need to go to. So you
can always ask for me if you're calling the hospital, if you need an answer to something. And we really appreciate your attendance here today. Tell all your friends, tell all your neighbors, tell all your colleagues that we're doing these great webinars, and we appreciate your support.